how do we contribute as a hematology laboratory towards COVID-19 management? So just an introductory slide. We are very well aware by now that COVID-19 is an infectious disease caused by SARS-CoV-2, which was first detected in December 2019 in the Wuhan province of China. And since then, it has spread globally across, forcing WHO to call it as an ongoing pandemic. Now, the influence of laboratory towards the management of COVID-19 is huge. The laboratory has its role to play in each and every aspect of management, right from when the virus is detected in the form of epidemiological surveillance by various diagnostics tests, antibody screening. When there is a florid infection, the etiological diagnosis is done by the laboratories. When there is an overt disease in the infected individuals, right from staging to prognostication to therapeutic monitoring, laboratory has an influence. And even when the patient has recovered, in epidemiological surveillance, the role of antibody testing comes into the foray. So we can say that laboratory test has a strong influence right from screening for diagnosis, etiological diagnosis, monitoring the evolution and complications of diseases like setting up of ARDS, thromboembolic phenomena, DIC, multi-organ failure, etc. Therapeutic decisions, therapeutic monitoring, prognostication of COVID-19, and epidemiological survey. Everywhere, our laboratories have a huge role to play. Now, coming to screening for diagnosis, when the patient presents themselves in the fever clinic, in emergency, in OPD, anywhere, the simplest test which the clinician asks for is a CBC, and CBC has a very prominent finding, that is that of lymphocytopenia. It's important to note the presentation when the patient presents to interpret this lymphocytopenia, because lymphocytopenia is more pronounced between 7th to 14th day of infection. What is lymphocytopenia? It's nothing but a lymphocyte count which is lower than the age-appropriate reference interval, for example, less than 1,000 cells per microliter in adults. It is a risk factor for progression to severe disease, so monitor the trend of lymphocyte count. And I would like to add here that it is NLR which becomes more pertinent, because NLR more than 3.13 is an independent risk factor for severe disease, and also the NLR helps us to differentiate the other causes for which the lymphocytopenia might have happened, say for example a marrow suppression. Now, what causes lymphocytopenia in a COVID-19 infection? To understand that, we have to know the pathogenesis of this virus in the host cell. The virus enters the host cell through ACE2 receptors, which is present on various host cells, including the lymphocytes. The virus has got these spike proteins on its envelope, which gives a distinct morphological shape to the virus, which we see even on roads nowadays. And these spike proteins are primed by transmembrane protein serine proteases present in the host cells. So since the lymphocytes also express ACE2 receptors on their surfaces, virus may directly infect these cells, and it ultimately leads to their lysis. There are also certain other mechanisms for causing lymphocytopenia in COVID-19, like the cytokine storm. Cytokine storm in COVID-19 is characterized by markedly increased levels of interleukins, especially IL-6, along with other interleukins and tumor necrosis factor alpha, which promotes lymphocyte apoptosis, leading to lymphocytopenia. Now, substantial cytokine activation may also be associated with atrophy of lymphoid organs, including the spleen, and therefore it further impairs the lymphocyte turnover. There is a distinct cause for lymphocytopenia more pronounced in patients with malignancies because of the coexisting lactic acidosis, which may inhibit lymphocyte proliferation. So we can see that there are multifactorial causes for lymphocytopenia, and that is why that is the most pronounced finding which we get when we screen a patient for fever suspecting a COVID-19 infection. Now, after we have done the screening, the patient, along with the chest X-ray finding, has been found to be a strong suspect for COVID-19. What do? We do a etiological diagnosis. And by now, all of us know that both WHO and Indian government, that is ICMR, have recommended RT-PCR, CBNAT, TrueNAT of respiratory samples, that is the oropharyngeal swabs, nasopharyngeal swabs from affected patients, to identify the presence of this virus. This also helps in epidemiology for case tracking, contact tracing, and containment of outbreaks. Here, hematology laboratory has not got much role to play, but the next step, which is the monitoring the evolution on the complications of disease, we have a huge role to play because the most common complication, most common evolution, which is also causing high mortality in these patients are the hemostatic abnormalities. The name has been given as CAHA, COVID-associated hemostatic abnormalities. Some people also call it as CAC, which is COVID-associated coagulopathy. So as the name suggests, the hemostatic laboratory role becomes immense here. Before going into that, we need to understand the pathophysiology of hemostatic disorder in COVID-19 infection. How does a patient lands up into CAHA? So what happens, the SARS-CoV-2 through the ACE receptors of the host cells, which are present in various organs of the body, right from endothelial cells in the vessels, lungs, heart, kidney, GI tract, biliary tract, so on and so forth. It activates these cells and there is an excessive immune response leading to cytokine storm, and there is an intense release of interleukins, gamma interferons, tumor necrosis factor alpha, and other inflammatory markers. This leads to a local and systemic inflammatory response leading to hypercoagulability, which is nothing but it is an imbalance of procoagulant versus anticoagulant proteins in the body, tilting the balance in favor of procoagulants. Also, there is an endotheliopathy where the endothelium switches to a procoagulant phenotype because it is injured and activated and becomes dysfunctional. There's vasoconstriction, there is activation of endothelial cells, platelets, leukocytes, and monocytes, increased release of von Willebrand factors, tumor factors, fibrinogen, factor VIII, thrombin generation, resulting in increased D-dimers, fibrin deposition, etc. Now, all this phenomena, it is catastrophic, it happens at a very fast pace, and it results in macrothrombosis as well as microthrombosis. Macrothrombosis, it causes venous and arterial thromboembolic events, resulting in pulmonary embolism, whereas microthrombosis, it causes multi-organ failure, microangiopathic, resulting in ARDS. So this is in short the pathophysiology of hemostatic disorder. And what do we do? This condition, there are certain risk factors which are present in the patient. In the presence of those risk factors, the condition of CAHA happens more catastrophically in the patient. Say, for example, prolonged immobilization, dehydration, acute inflammatory state, presence of other cardiovascular risk factors like hypertension, diabetes, obesity, or cardiovascular diseases like coronary artery disease, history of ischemic stroke, or peripheral artery disease. That is why there is a consensus that patients with comorbidities like these perform a little badly in COVID-19 infection. Previous history of VTE and a classical genetic thrombophilia such as heterozygous factor V latent mutation are another risk factors. Also mechanical ventilation, central venous catheterization, previous surgeries. Patients having all this are at increased risk for hemostatic abnormalities in COVID-19 infection. Now, what do we do when the patient is having this kind of disease evolution or this kind of complication? We have to monitor the hemostatic status of the patient, the hypercoagulable state. There comes the role of hematology lab parameters, the most important of which is D-dimer. D-dimer is the best currently available laboratory diagnostic marker for hypercoagulable state. Papers have been published which say that cutoff of 1.5 microgram per ml for predicting the venous thromboembolism has demonstrated a sensitivity of 85% and a specificity of 88.5% and negative predictive value of 94.7%. So this is the marker when it comes to a hypercoagulable state detection, and it has been included in the protocols of investigation and management of COVID-19 across all states. PT more than 3 seconds, PTT more than 5 seconds, fibrinogen higher level, platelet count increased, all these are other markers. We have to keep in mind that if we are reporting a PT in terms of INR, subtle changes might go undetected because there is not a marked increase in PT or PTT, it is just more than 3 seconds. Antithrombin 3 also is reduced, but not less than 80%. But since this is a marker which is not commonly available across laboratories, its role has not been all that pronounced in detecting the hypercoagulable state. But if it is available and we can do it, and we can do a study to find out how much levels are really reduced quantitatively. Now, this is a beautiful paper where an attempt has been made to stage the COVID-associated hemostatic abnormalities in 3 stages, and this has come from as near as CMC Vellore. Alok Srivastava has been a co-author for this paper. And this staging, this clinical staging has been dependent upon 3 markers coming from hematology laboratory: the D-dimer, the platelet count, and a PT or a APTT. CAHA has been divided into stage 1 if the D-dimer levels are just 2 to 3 folds, platelet count normal, PT-PTT normal. Stage 2, when the D-dimers are 3 to 6 folds, platelet count as there's mild thrombocytopenia, and PT-PTT minimally prolonged. And a stage 3, where the D-dimer is greater than 6-fold above the normal platelet count, there is moderate to severe thrombocytopenia and marked prolongation of PT-PTT. Stage 1, as we can see in this diagram, usually clinically not discernible, sometimes even missed on radiology. There is a microthrombi formation in the peripheral parenchyma of the lung. Here there is a disseminated microthrombus formation all across the lung, and in stage 3 there is also a systemic thrombus formation. So depending upon these stages, the care of the patient is decided whether they will be in ward, they would be in HDO ward or ICU, or in stage 3, definitely they go into the ICU. Also, the further testing depends upon the staging, and of course, the therapy questions, the therapy answers, the therapeutic decisions are made based on these staging, which is based on 3 simple markers like D-dimer, platelet count, and PT or an APTT. Now, once the patient is in hypercoagulable state, there's a next step of complication which can ensure, which is a DIC. Now, disseminated intravascular coagulation, we have to understand, in COVID-19 patient is little dissimilar from the DIC which happens in other conditions. Here, the increase in D-dimer is multifold compared to other DICs, and also the fall in platelet count is not all that pronounced. So seeing a moderate to severe thrombocytopenia in DIC associated COVID-19 is not all that common as seen in DIC of other disorders. Now, Scientific and Standardization Committee of ISTH has recommended actually a very robust scoring system since ages. I think the first paper came in 2006 for scoring the DIC and to differentiate between an overt and a non-overt DIC. Now, presence of an underlying condition known to be associated with DIC is a prerequisite for entering into this scoring system. If that prerequisite is not there, we do not do a scoring system. If the prerequisite is there, then based on simple tests which are available in all laboratories, like a platelet count, like a PT, like a fibrinogen, and a D-dimer or an FTP, the scoring is done. I will not go into the details of that scoring that is available on the internet all over. Based on the values which we get in those 4 parameters, we score the patient, and if the score is more than 5, it is indicative of an overt DIC, and we have to do the scoring daily. If the score is less than or equal to 5, it is indicative of a non-overt DIC, and we have to repeat the scoring every 1 to 2 days to see whether the patient is slipping into an overt DIC. Other than hypercoagulable state, CAHA, and DIC complications, there are certain other complications which can happen in COVID-19, like a bacterial infection, where again, hematology laboratory CBC plays a role. It shows leukocytosis with neutrophilia, along with certain other peripheral smear findings, which we can see in multiple bacterial infections, like toxic granulation of neutrophils, Dole bodies, sometimes RBC fragments, and of course, the diagnosis is confirmed by blood culture. Then as the patient slips into multi-organ dysfunction, various biochemical parameters come into foray like LFTs, RFTs, CRP, LDH, procalci, ferritin, CPK, troponins, etc. And the cytokine storm is diagnosed by a very recent test added into all of our menu, which is interleukin 6. So after monitoring the evolution of the disease and the complications and finding out whether the patient is in CAHA, in DIC, or any other complication, next step is, of course, a therapeutic decision. Hematology lab also has a role to play in therapeutic decisions because D-dimer, when the D-dimer is elevated more than 6 times the normal, low molecular weight heparin is especially indicated. Also, the platelet count has its role to play because when a prophylactic dose of LMWH for severe disease is recommended, unless there is an active bleeding or a platelet count of less than 25,000, we can always give a prophylactic dose of LMWH. So we have to give our platelet counts accurately, we have to give our platelet counts fast, because a decision on prophylactic dose for LMWH awaits our platelet count. After the therapeutic decisions, what do? We do a monitoring of this therapy. So for therapeutic monitoring, again, it is done on the basis of D-dimer, the falling or the increasing levels, on the basis of prothrombin and platelet count. Monitoring of LMWH, we have to consider an HIT, that is heparin-induced thrombocytopenia, even if the platelet count is normal. So though the nomenclature says HIT, which is thrombocytopenia, but the platelet count may be normal and the patient may be having HIT, we have to see that the decrease has not been more than 50% in 4 to 14 days of commencing the heparin treatment. If the platelet count has fallen to more than 50% into 4 to 14 days of commencing the heparin treatment, it may be so that the patient is undergoing into a state of HIT, and we have to investigate on those lines. After therapeutic monitoring comes the prognostication. Prognostication again is based, the most important, a very common, a very economical marker is lymphocytopenia. It is a risk factor for progression to severe disease. So monitoring the trend of lymphocyte count is extremely important. NLR, which is neutrophil lymphocyte ratio more than 3.13, is an independent risk factor for severe disease. Platelet count is important because the platelets get activated, they get increased in number in hypercoagulable states, they get decreased when the DIC is ensuring, though not to very high levels, and again any improvement in the platelet count is an indication of the improvement in the clinical condition of the patient. So it's important that we monitor the platelet count and explain the prognosis according to them. Then, as I explained earlier, coagulation parameters indicating DIC and hypercoagulable states like PT, PTT, fibrinogen, D-dimer, all those are important. Interleukin 6 and NT-proBNP, all these help in the prognostication on how the patient is going to perform. Apart from this, in hematology, we find certain smear findings. There can be apoptotic hypolobated neutrophils, reactive lymphocytes, and RBC fragments in cases of DIC sepsis, along with toxic granulation and Dole bodies. But they may not be present in all the cases. Right now, we are doing a kind of a study to find out how many of our cases showed these morphological abnormalities, and we would be ready with that soon. So this is a summary of the basic hematological biomarkers which get deranged and their clinical significance. Lymphocytopenia, which is indicative of a defective host response. Leukocytosis is because of bacterial superinfection. Neutrophilia because of bacterial superinfection and cytokine storm. Then a thrombocytopenia, prolonged PT, prolonged APTT, increased D-dimer, etc., which is indicative of a CAHA or a consumptive coagulopathy. Then there are some futuristic markers which are not so much contributory today in management of COVID-19 infection, but definitely they need to be looked into once we are settled with our management of COVID-19, because they have huge contribution to play towards the pathogenesis and other information on the disease, like a tissue plasminogen activator. It is the crux of the entire CAHA. Because of tissue plasminogen activator, it is increased up to 6 times. Papers have been there in non-survivors, then survivors, and it is the cause for increasing D-dimer levels in COVID-19 infection. Anti-10A assay is important to monitor the low molecular weight heparin accurately. Lupus anticoagulant papers have been published where they have said that lupus anticoagulant has been found to be positive in COVID-19 infection, and it can contribute towards the hypercoagulability in the patient. But for us, in almost 450 cases, only 2 lupus anticoagulants were ordered, and they both were negative. Antithrombin levels do fall, but not beyond 80%, so they can be monitored. Investigation of HIT is important. CD4 to CD8 ratio. It has been seen in papers that a decrease in CD4 count has been associated with poor outcomes, increased mortality. Von Willebrand factor, ADAMTS, EGF, these are all indicators of endothelial cell activation, have a role to play. So these can be the futuristic markers for COVID-19 management. Also, neutrophil CD64 expression, mean cell volume of neutrophils and monocyte, immature granulocyte fraction, delta neutrophil index, and monocyte distribution width all are indicative of an ensuing sepsis. Then application of simple data derived from CBC to use the formulas such as neutrophil lymphocyte ratio, which is rampantly used everywhere now, very actively used, platelet to lymphocyte ratio and monocyte to lymphocyte ratio to act as a surrogates to assess the extent of systemic inflammation can be done. There is also an evidence of virus shedding in urine, but however, the duration and frequency of this shedding is not yet known, so we cannot really use urine as of now for detecting the presence of virus. A paper has been published again from China where the nucleocapsid protein in urine was detected in 73.6% of the diagnosed COVID-19 patients. Also, urine as a marker for disease severity and prognosis is being talked about, is being explored. In a study comparing 119 COVID patients of varying degree of disease severity with 45 healthy volunteers, there have been positive findings in occult blood and proteinuria, in specific gravity, which was lower, pH, which was higher, and positive rates of urine glucose and proteins was higher in severe and critical patients as compared to moderate groups. But here we have to keep in mind that most of these patients who are critically ill have comorbidities like diabetes and hypertension. So whether those comorbidities have contributed to these findings in protein or it is because of the COVID-19 infection, we have to find out. So this important trend observed in the study should be confirmed in a study with a bigger sample size, and we are thinking of taking up that as well. Now this in short, this is not our entire experience in Apollo. This is the first 50 cases which we got, I think, early in the month of May or April or May. More analysis is underway, and then we'll be able to present with a more robust data, but this is just an overview. We have seen the abnormalities across all these hematological parameters. D-dimer has been found to be high in 58% of the cases, out of which 55% had a severe elevation of D-dimer, that is beyond 6 folds, more than 3. PT, PTT were not very contributory. 18 to 20% of the cases had PT, PTT positivity. WBC count was increased in 32% of the patients. Neutrophil lymphocyte ratio was a single marker which was most significant. It was high in 62% of the cases, and the next set of data, which is on bigger study population, says the numbers to be even higher. Of course, lymphocytopenia was in 28 out of these 31 patients, and all the patients with lymphocytopenia presented with an increased NLR. Platelet count was abnormal in 22%, but predominantly it was increase in platelet count which was seen. Thrombocytopenia was seen in only 4 of these patients, out of which 2 had severe thrombocytopenia. But the thing is that everyone who had a severe thrombocytopenia did not do well. So both these patients with intense thrombocytopenia did not perform well. So this was regarding the laboratory contribution, but since the laboratory has such a strong influence and such a huge role to play in COVID-19 management, it is important for us to keep ourselves safe and our laboratories safe. So it is noteworthy that although the predominant route of spread of COVID-19 is respiratory, approximately 1% of blood specimens tested by RT-PCR have evidence of COVID-19 viremia. Thus, though rare, infection through contaminated blood is possible. And it is not the first time that the coronavirus is familiarizing itself with humans. We had earlier incidences of SARS and MERS, but the uniqueness of this COVID-19 is that it is especially extremely bad to healthcare workers. A lot of healthcare workers are getting infected with it, and there is some publication to corroborate this fact. Chinese Center for Disease Control and Prevention has indicated that 3.8% of all COVID-19 patients were healthcare personnel, and this peaks to as high as 63% during the initial outbreak in Wuhan, and with nearly 15% of these experiencing a severe or a critical form of disease. Also, some data has come from Italy, which says that infection rate of healthcare workers among the total number of COVID-19 patients was 10.7, which is quite a high number. Also, the possibility of SARS-CoV-2 transmission by asymptomatic or mildly symptomatic individual is a huge area of concern. These are the ticking bombs, and it is not helped by the fact that the viral load in an asymptomatic or a mildly symptomatic individual is almost similar to a viral load in a symptomatic individual. So there's a lot of spread, up to 40 to 60%, which happens within the laboratories through asymptomatic individuals. So appropriate PPE at all times is a must to safeguard ourselves. So this is my concluding slide. It says that COVID-19 is primarily manifested as a respiratory tract infection, but emerging data is indicating that it should be regarded as a systemic disease involving multisystem like cardiovascular, respiratory, GI, neurological, hematopoietic, and immune system. Careful evaluation of laboratory indices at baseline and during the disease course can assist clinicians in formulating a tailored treatment approach and promptly provide intensive care to those who are in greater need. So it helps us to rationalize the limited resources that we have. Preventive measures for thromboprophylaxis and early identification of potentially lethal complications, including DIC, in order to effectively intervene, will improve the patient outcomes and will probably reduce the death rate overall and among infected patients without significant comorbidities. So this is just to show how important laboratory is towards the management of COVID-19 and to reduce the morbidity and mortality in these patients. Since we are so contributory, to facilitate our contribution effectively and efficiently, we have to be prepared for this COVID-19 as laboratory professionals. There should not be any cutting of the lab resources because of lack of work, because the work which we are receiving now is important, intricate, and complex. Also, we can try to reinforce the network of regional labs. We can install mobile labs that will reduce the movement of manpower, movement of samples, and help in the containment of disease. Also, improve the turnaround time, which is extremely important. As we saw, a prophylactic decision awaits a platelet count, so we have to give our reports faster. Of all, the most important is that we have to do a risk assessment and establish a lab contingency plan for this pandemic. With this, I thank you for your patience, for your time, and for your attention.